Okay, now better. Okay. Okay, so I'm gonna tell you today a story that is the story of a professor that was the first one discovering genetics and trisomy 21. And I'm gonna tell you this story because it's actually the same thing that is happening to us back in a small town in Italy that is Bologna. And by the way, all the pictures that you will see in this presentation, these are our patients, and this is us, like the healthcare, so real picture. So trisomy 21 was discovered by John Langdon Down, from which the name of Down syndrome, in 1866, but it was just discovering all the characteristics. It was just in 1959 that Professor Jérôme Lejeune found the cause of trisomy 21, the presence of an extra chromosome 21 in a patient affected. And this was a huge change in history because before that, it was thought that the children with this condition were like that because maybe parents had did something wrong, for example, alcohol abuser or whatever, and they were kept closed in the house because of shame. So it was a big change for the families and also for the children because they finally were able to discover the world. Here I reported two quotes that Professor Jérôme Lejeune said, and it was that he was really convinced that there was something to discover and that it could improve lives of 1,000 of people, and then that if you could find a way to cure trisomy 21, then all the other pathologies, genetic pathologies, could be cured as well. Just a little reminder of what is trisomy 21 for who doesn't know. It's a syndrome, so we have a lot of comorbidities and a lot of facial features. These are the Jackson signs that were used back in the days, now we use genetics, as you all know, to make a diagnosis of trisomy 21. We can have a lot of comorbidities, and here I report all the percentages. And we have as well intellectual disability that is specific of trisomy 21. So it's a specific intellectual disability linked to trisomy 21. We have some areas of weakness that is psychomotor development, abstract thinking, and language. And instead, they are really strong in social and emotional sphere. So as we were saying, it can affect a lot of organs. It's highly heterogeneous, and obviously it can affect different parts depending even on age, so it can get worse. But what is always present in trisomy 21 is, in 100% of cases, is intellectual disability and the typical features that you can see as, you can recognize. So here are all the people that are part of our project. There's the University of Bologna, and then there's the hospital in Bologna, and also we work with Engineer University of Bologna and also University of Padua, so to say that it's a multidisciplinary work. So I'll divide this presentation in two sections, and in the first one we will see the molecular aspects and the things in which we're doing research. And it's really impressive because actually we didn't discover anything because we're just following what he was saying in 1977. So he said that all the disease that he was studying, in his opinion, had something to do with a cycle that is called one carbon cycle, and that we started to study it to see if his intuition were actually right. Yes, it's really complex, but I'm trying to make it as simple as I can. This is the one carbon cycle, and it's really important for DNA synthesis, for amino acid homeostasis, for antioxidant generation, and for epigenetic regulation. So we ask ourselves, but is this cycle linked to intellectual disability with trisomy 21 being always present, intellectual disability? And if it's so, is there a way we can try to solve this problem, to fix it? Here I reported how is the cycle dysregulated in trisomy 21. So as you can see, there are lots of metabolites that are not as we wish to see, like in a normal person. I want to put a focus on the tetrahydrofolate, that is this one, that it's here, that is a reduct in trisomy 21, and here it's here. But this picture is just to let you see, like visual, how many pathways recreate the tetrahydrofolate. So as Lejeune was saying, if there are so many ways that try to restore it, it means it should be really important, because there are a lot of things that try to fix it in order to understand that it's really important for human life. And in fact, we found out that it's the dysregulation that we see in trisomy 21 is the same dysregulation that we see in the chromosomal imbalance. So seeing that we have a proportion of 3:2:2. And this was really amazing for us and for people that study medicine and genetics, because we were seeing the same imbalance seen in chromosome. That's why we thought to start a clinical trial on our children, trying to restore the imbalance that we saw at the metabolite site, giving 5-methyltetrahydrofolate. We will start hopefully next year, and it's going to be a clinical trial with a placebo control group, and it's going to be quadruple blind, so it's a really huge work. And I reported here one of the sentences that always Lejeune said, that find a cure for trisomy 21 was less challenging than sending a man to the moon. So hopefully we will see. But going on, I reported here one of Jérôme Lejeune's sentence while he was discussing his PhD. First of all, because I'm going to discuss it in a few months, so I want to be inspired, but also because he was saying, while I'm studying all these chromosomes, what are we doing for these children? I feel like we're not doing something good enough. And that's where all the clinical aspects began. So it all began with these 3 people. The one in the center was the first professor. Now he's retired. He was a neonatologist. And he started to follow children with trisomy 21. So he started to follow them, and he had something like 10 to 12 patients. Nowadays, we have 330 children with trisomy 21 in our outpatient clinic. This year, we had 41st visit of children with trisomy 21. The average time for a visit with them is 2 hours. Families are coming from all over Italy and also beyond in Europe. And there is our follow-up. So from 0 to 1 year, we do 4 visits per year. From 1 to 3 year olds, we do 2 visits per year, and then 1 visit per year. I just want to mention that there are 3 of us clinicians, and the professor triple that is doing research, and none of us is paid by the hospital for doing that. We're like hired for doing something else. So we're doing it, like, let's say, in our free time, but as you can see, the amount of work, it's a lot. This is us, actually. And what happened, really surprisingly, is that by concentrating so many children with trisomy 21, we were not expecting that, but it happened, unintentionally, the Bologna Hospital became a center with really extensive experience in treating all the comorbidities of these children. So it's becoming a true reference center in all Italy. But what we're trying to do is considering the life as a whole of our patient. So we're trying to fix their medical problems, but we're trying also to fix or being there for the problems of daily life. We listen to parents. We try to figure it out, to put all the checkups in the same day, so parents can go to work and children can go to school. So we try to understand what also are the inclination of the children that we follow in order to help them. For example, like a few months ago, one of our child wants to go to work to a shop, like selling clothes, and we called the owner of the shop just to say that he was able to do this job because the stigma is still there, you know. And listening to the parents, we understand what were the first difficulties, and one of them was obviously speech therapy. Because as we were saying at the beginning, they are weak in language, and speech therapy in Italy is free, but it becomes at 3 years old of age of children. And with the research, we found out that as soon was the better for them to start. So we organize a program that is a speech therapy program that is totally free for the parents, and it's called Watch How I Grow. And with that, the percentages of our cohort of people with trisomy 21, like the percentages of them speaking, is higher than what was before. And even when they start to eat after the breastfeeding and everything, we were able to find a way to help them, just their difficulties, and now most of our children are able to start to eat and have less masticatory dysfunction. Again, during COVID-19, we were not able to help them to see our patients because of COVID, and our families felt really by themselves and alone. And we found out there was an area that we were not considering, that was all the psychological problems and issues that a family should encounter. And that's when we thought to start a psychological project, again, totally free for our families, that is called Keep Talking to Me. And all the psychologists that are really specialized in trisomy 21 help our families. It's for the parents. For example, when their child has to go to a new school, how to explain this to them, or when they fell in love, how to explain this to them, when they have to find a job, and everything. And again, totally free. But because we were not happy enough, as one of the biggest doctors curing these children, that is Giancarlo Rastelli, that was a young doctor that found a way to cure the complete atrioventricular canal defect. That is, it's one of the most common cardiopathy in trisomy 21. He always said that the first charity for the sick is science, and so we start to ask to our parents what they need the most. We designed a survey on a platform and divided it on prenatal care, postnatal care, and future perspective, with a small focus on breastfeeding, to ask them if there was something we were doing right and something that instead we can ameliorate. We obtained a lot of answers, and we were not expecting that. So even regarding to the literature review, having 86% of responses are really high data. And here reported just a few, I'll just focus on a few things. Regarding the prenatal period, a lot of parents said they felt judged that they should terminate the pregnancy. And regarding instead the postnatal, they didn't know how to raise a child with trisomy 21, and they all have future concerns on how their child will do without them, if they will be able to socialize, if they will be autonomous. So regarding the prenatal period, we designed guidelines for how to communicate diagnosis, whether in prenatal period or postnatal period. And we really focus on what is, you all know, is like to take care of them. So to make some space for parents to ask questions, call the baby by his name, even if it's still in the belly. Just give all the therapeutic possibilities if they're available. Talk about the comorbidities that are present in the child you're talking about, not all the comorbidities that the child could have. And also emphasize what you can do for them. And again, we found out, as you may know, that when there is a genetic condition, there is a sort of clinical assistance when the patient is a pediatric, but then in Italy, is 18 years old, everything stops. No more height, no more money from the government, anything. So what we're trying to do is to establish a multidisciplinary team that is made by the pediatric staff and also the geriatric staff, because they have all these comorbidities that should be taken care by someone that has an open view of the patient itself. And we start to put all this clinical data together, and as you can see here, we start to see what were the most important insights to take care of in the pediatric period, and how they switch in the geriatric one, in order for us to be aware on what to look and what to not look. And we're trying to do the first follow-up that is for all the lifespan. So in conclusion, what we're trying to do is to put all this data to make a great difference for them in their life, while we're trying to find, let's say like that, a cure. And this is us in our polyclinic, and I'll just want to finish with one of the sentences of Professor Lejeune that said that the dream of my life is that a person with trisomy 21 will be appointed professor as the Faculty of Medicine, and as you see, is becoming a doctor. Thank you so much.